ready to start the program again with two of our incredible speakers. We're very excited to invite back in person this year Dr. Dolores Shoback, and she's going to talk to you a little bit more about your bones. So welcome, Dr. Shoback.
Thank you so much for having me and introducing me, and I want to thank the association for inviting me to present today. So we're going to talk about bones and PTH today, and I have a couple of disclosures that I've put on the slides here, and these slides will be available to you on the website. And we're going to talk about medications in part that are not FDA approved. I'll mention that as well. So what I'm going to try to do is talk to you a little bit about the biology of PTH. You've heard a lot about it, the molecules that are being used and sort of the molecules in our body, the physiology and actions as it mostly relates to bone, and then how we assess bone clinically. And there's been a lot of talk about bone, so maybe this is too elementary, but we'll talk about how we assess bone both clinically and also in research settings. Then talk a little bit about what PTH deficiency does to our bone, both chronically and acutely, and then PTH therapy, and then what happens to the bone when it's exposed to PTH. Now we're going to talk about, and you've heard a lot about already, bone turnover markers. We'll drill down on what they are and what they tell us, and maybe what they don't tell us, right? And then bone mineral density. And the molecules that we'll talk about are here. I've listed them all, and you've heard a lot about them in the course of this really wonderful, wonderful weekend presentation. So you've seen a million of these, and this one is just another one to remind you how important the parathyroid glands are in maintaining the calcium in our bodies. And we're going to focus over here today in this particular lecture on the bone. And there's sort of two main processes that are important in the actions of PTH and in the maintenance of bone mass. And those are bone resorption, that means the breakdown of the matrix or the mineral phase of the bone, and new bone formation, that's putting it back or building it to begin with. And so those are the two processes we're going to concentrate on. And as you know, these are critically important, as well as the kidney, and we'll leave that aside for the purpose of this lecture. But this is critically important in sort of the chronic maintenance of our serum calcium levels. So we know that the parathyroid glands produce PTH, and they have incredibly important effects on these different mineral parameters. But you see bone turnover, as I've highlighted it here. That's one of the critical actions of PTH in its maintenance of the blood calcium level. And when PTH is present, you've got a maintained normal level of bone turnover in your body. And when PTH is missing in hypopara, one of the many effects, and it's buried over here at the bottom of the list, but again, critically important, is that maintenance of a normal level of bone turnover in our bodies. So just a couple of things, this is sort of bone 101 in certain ways, but just a couple of things you've kind of heard about the hip, you've heard about the radius, you've heard about the spine. Why do we assess so many different places in our skeleton when we look at bone? And that's because bone at the different sites, and we're going to talk about the spine first, has a different structure, sort of different properties, and it responds differently to the hormonal challenges that occur. So the bone in the spine, and here's the spine in sort of this cartoon form, and when we measure bone density or bone mass, we're going to be measuring it here in the lumbar spine, L1, L2, L3, L4, okay? So the bone in the spine is really unique. It's got this spongy appearance, and we call it cancellous bone, or you might hear people talking about trabecular bone versus cortical bone. And that's because of the way that this bone is sort of built up, its composition and its microstructure, if you will. And the bone in the spine is very metabolically active. It's vascular, it's porous, it's got a big surface area, it's got a complicated structure, but it's very metabolically active, okay? And that's really important. That's really important to exchange the minerals across that matrix, and it's very important in hypoparathyroidism because that is not happening, that mineral exchange. And of course, the bone marrow also makes blood cells. So that's the bone in the spine. Now, the bone in the hip is a little bit different, and you can see its structure is laid out here on this slide. On your left, you've got the normal sort of hip in cross-section. It's got a complicated architecture. It's got that trabecular or spongy or cancellous bone in the middle of it. And then it's got the cortical bone that gives it its strength surrounding that center of trabecular bone. So it's also complex. And many of us think about the thinning that occurs in a bone like the hip as we get older or with diseases like hyperparathyroidism, because both of those compartments of bone in this very important structural bone thin out with osteoporosis, for example, or with the aging process. Okay, and this is a bone as well as the spine that changes with aging and with osteoporosis. And as I've really already said, when we measure the bone, we'll often say bone mass or bone mineral density, and those are interchangeable kind of concepts or terms. And you'll also hear the abbreviation BMD as for bone mineral density. What we're talking about is mass, really. And then finally, the other site that we typically measure in research and in clinical care is the forearm, the radius, okay? So we've got two bones there, and it's the radius that's this one that's sort of in the, facing the middle part of your body, and it's shown right over here. And this also is a bone that has a pretty complicated and very important structure and structural features to it. And you can see that in cross-section over here. You've got cortical bone on the edges, trabecular bone in the middle, and depending on where you take your assessment, you may see a very different pattern, and you can see that over here, a very different pattern of bone in its organization and in its mass in this part of the radius, for example, versus this part of the radius. And when we report this out, like on the DEXA scan reports, and we'll look at those in a moment, we're reporting out the bone, the measurements of bone over here in this 1/3 distal radius. So how do we assess bone? You've been hearing about this in all the talks that you've heard this weekend. Well, we actually start really, I think, by asking you questions. Have you had a fracture since your last visit? Do your bones hurt? Do you have bone pain? And we had some people talking about bone pain in response to starting PTH therapy. So those are ways clinically that we find out something about your bones. Otherwise, we end up with measuring bone by imaging, and you've heard a lot about that. And we also measure what's going on in bone by blood tests. So what's involved here? So typically, we are measuring bone in clinical care with a DEXA scan. And that term or that abbreviation means dual energy X-ray absorptiometry. Okay, and it can be applied to the three bones that we just talked about, the spine, the hip, and the radius or the forearm. You can also do a quantitative CT scan of the bone. That's not used very much clinically, but it can be done. And for research, we can use a high-resolution peripheral QCT, and that's being done in some of the research studies that are out there. In addition, we've talked, and you've heard a lot about the bone turnover markers, and those are blood tests that we use to assess what's going on in the blood based on what's happening at the tissue level in bone. And for research purposes, we can actually also do bone biopsies, so those are very rarely done for clinical care. And in a sense, they tell us at the cellular level, when you look at under the microscope, what's going on in bone. So we're going to talk first about DEXA scans. So how many people, I want to take a poll, a quick poll. How many people are patients with hypoparathyroidism in the room? Okay, keep your hands up if you've had a DEXA scan. Okay, good. It looks like everyone's got their hand up, so it looks like this is happening. So just for those who haven't had the scan or who are new to this meeting, this is a technology that's very straightforward to use. It's painless, it's non-invasive, low radiation exposure, and again, it looks at those sites that we've just talked about. So it seems like this is getting done in regular care for people with osteoporosis. Now, here are some sample reports from a DEXA scan, and we'll walk through those. How many of you have looked at, of all those people that raised their hands, there are quite a few, how many of you have kind of gone over your DEXA reports? Okay, so it seems like about half or so. So good. Well, maybe this will help the other half kind of go over those reports and feel more comfortable with it. Or if you've looked at them and just walked away scratching your head, maybe this will help understand the way these are put together. So over here on your far left is the lumbar spine, okay? And what you're looking at in the green is kind of a normal bone density. What you're looking at in the yellow would be kind of osteopenia, and what you're looking at, it's color-coded in the red, would be osteoporosis or an increased fracture risk. And so this little dot or this little X would mark the particular place where your bone density is plotted on that particular scale. And then over here, this little table is going to give you the bone mineral density in grams per centimeter squared and the T and the Z score, and we'll talk about those in a moment. Over here is the hip, and the different boxes are what we call the regions of interest in the hip, either the total hip or the femoral neck, which is this area right here. And again, the same color coding and the same kind of table giving you those measurements that were obtained on your DEXA and how that relates to the control population. And a lot of the DEXA reports will also report out some FRAX scores as well. And then over here on your right is the radius, the measurement at the radius, and again, the same kind of plot. And many of the reports will also have a table that looks like this, and it'll just show the different regions where they take measurements. And then generally at the radius, for example, we're looking at the 1/3 distal radius as a thing that we read out. Okay, so we've already defined BMD, and you'll hear people use that term frequently. We've talked a little bit, I've mentioned to you T-scores and Z-scores. Now, what are they? So the T-score is the number of standard deviations, and I'll show you the curve in a moment, that your bone density is. If it's above the average, it'll be plus. If it's below the peak bone mass, it'll be negative, okay? And we use the T-score if you're a man over the age of 50 or you're a woman over the age of 50 or postmenopausal. Okay, so that's the T-score definition. Now the Z-score is again standard deviations above positive, below negative, for someone, comparing you to someone your age and same sex, okay? And that is used for people under the age of 50, all right? And we use this because it just allows us to kind of compare to a normal population and also compare across countries and so forth. It's not like a blood sugar. We say your blood sugar is 95. Here we use T-scores and Z-scores more as a way to kind of communicate that same kind of information. Okay, so that terminology is important to know. And then here's the bell-shaped curve sort of for bone mineral density, okay? And a T or a Z-score of 0 is right here at the top, okay? And if you're above that, it's on this side of the curve and it's positive. Those numbers are positive. And if you're below that, it's over here to the left, and osteopenia starts at a T-score of -1 and goes to a T-score of -2.5, and then numbers below that over here are osteoporosis, okay? So just trying to get us all on the same page with understanding how these things are read out. And this is just a simple, same kind of table that shows you the T-scores over age 50. High bone mass is greater than +1, normal, -1 to +1, osteopenia, we've just defined it, and osteoporosis below -2.5. So that's the accepted way of kind of thinking about and diagnosing osteoporosis by densitometry. Now the Z-score maybe doesn't get used quite as much or thought about quite as much, but again, we use it in people who are under the age of 50, and you'll see some of the data that we talk about with regard to PTH therapy in terms of T and Z-score. So I think it's important to spend a little bit of time on that now. But a Z-score, for example, below -2, is going to either indicate you have a low peak bone mass, you didn't achieve the sort of the peak bone mass of people in your sex, between age 20 and 29. And if you're below -2 or -2, or you have accelerated bone loss. So that would be the way to kind of define low bone mass or osteoporosis in a younger person. We use the Z-score and that particular number, or if there are fractures present. Okay, so that's T and Z-score is kind of how we use them. And then there are, and you've heard a lot already about the bone turnover markers. Now, the ones that we currently use are blood tests. There are urine tests for bone turnover, but we typically use, and pretty much the field has moved toward using blood tests for this. So the bone-specific alkaline phosphatase is one that is used in lots of studies and is easily available. And that reflects what's going on, the activity of cells in the osteoblast lineage. Those cells are the ones that make bone-specific alkaline phosphatase. The two that you've heard the most about over this weekend are the P1NP and the CTX. And the P1NP, here's what that abbreviation stands for. It's a portion of the type 1 collagen molecule that reflects the activity of osteoblasts, the bone-forming cells. So it's a bone formation marker, and it's the best formation marker that we have. So that's what's being used in the research studies. And then the serum CTX is C-telopeptide. That's what that stands for. And it reflects the breakdown of type 1 collagen. And sort of here's a little cartoon to kind of illustrate all of that. And it reflects the amount of bone resorption that osteoclasts are taking part in at that moment in time. Now, these levels have a lot of things that determine what they are. Your age is important, your sex is important, menopause, menopausal status, medications you're taking, any other illnesses. But PTH, I've highlighted it here, is incredibly important. And if you remember from those physiology diagrams, bone turnover is very importantly determined by PTH. So these markers are affected by the level of PTH in our bodies or if we're taking PTH therapy. So those are the bone turnover markers that we'll talk about. I've mentioned bone biopsy, and maybe some of you have participated in some of the research studies, have had this done, but we hardly ever do it clinically. But it is sort of a very accepted sort of gold standard to look at what's happening in bone as a tissue, but much more of a research tool. So these are just some pictures of bone that have been, this is from the work of Dr. Rubin and Dr. Bilezikian, and what you're looking at over here is a bone biopsy taken from the iliac crest, okay, in a normal person. And then once it's taken out, it can get stained in certain ways, and we can look at the thickness of the bone, and we can look at the activity of the cells. So this is normal bone, and here's a piece of bone from a person with hypoparathyroidism. And I think right off the top, you can see that the thickness of the cortices, these are the bone cortices we talked about, and the trabecular bone here is thicker and greater and denser than in the normal control bone over there. So that's one way to think about this. This is reflected. The stuff that we're measuring by DEXA, the stuff we're looking at with bone markers is reflected in what's going on at the tissue level. And when you take a bone biopsy, you can also subject it to micro-CT scanning. You know how we scan major organs? You can also scan little pieces of tissue. And so over here, we're looking at a piece of bone scanned from a person with hypoparathyroidism compared to a control. And again, this density that we're seeing up here, we're seeing it down here as well. You can see, think of this control bone as like a piece of Swiss cheese with lots of open spaces in the middle of it, where all that mineral exchange takes place, for example. And so that's all happening over here. But you can see in the hypoparathyroid bone, that bone is packed in, and those areas of trabecular activity are reduced. So we learn a lot from looking at bone by these different techniques. Now, I think Dr. Rubin talked a little bit about bone remodeling, and I want to talk a little bit more about that because I think it's incredibly important to understand when you're trying to look at the effects of an intervention on bone. So this bone remodeling is something that is happening 24/7 in our bodies. If you think of your skeleton as a house with 10 rooms in it, as an adult, one of those rooms is constantly undergoing remodeling. Once it's remodeled, your body moves on to the next room and remodels it. So this is an active process in our bodies at all times. And it's got a bunch of phases. Right over here on the far left, you're looking at a piece of bone that's in the resting phase. When some kind of signal comes, perhaps from the osteoblast, when PTH is talking to it, goes to the osteoclast and stimulates this phase of bone resorption. All that bone and all that mineral get released into the circulation and the body deals with it. After a couple of weeks of this kind of activity, the process starts to reverse itself and the osteoblasts, the bone-forming cells, come in here and fill in that divot that was created, new bone is formed, and it gets mineralized, and the process restores itself. And at steady state, what gets resorbed gets reformed, and everything stays stable. And this is going on, as I said, all the time. And many, many of the cells that are here in this bone remodeling unit are responsive to parathyroid hormone. They're responsive to many hormones, but we're going to focus on parathyroid hormone. And they're affected by the presence of hypoparathyroidism. So this is an incredibly important process. So what does PTH actually do when it hits our bone cells? And you've seen some of them right over there. Well, it binds to PTH receptors, and we've talked about those with regard to the different treatments that we have for hypoparathyroidism. But the most important thing is that those receptors are on these different cells. And the main job in defending the serum calcium is really the mobilization of calcium out of that matrix into the circulation. And again, that's going on all the time. And it happens through a process whereby these osteoblasts, those bone-forming cells, make a protein called rank ligand. And it's that protein that goes to the osteoclast, talks to them, and initiates that initial step in bone remodeling that we just looked at. PTH also stimulates bone formation. And it's a complicated hormone when it comes to bone. But the main job for us today in thinking about hypoparathyroidism is this maintenance of calcium mobilization out of the skeleton. But in the process, there's probably also some stimulation of bone formation that's going on as well. And you'll see that reflected in the bone turnover markers. Okay, so we've talked over the course of the last 2.5 days or so about a lot of different forms of PTH and PTH analogs that are being used in clinical care and are being tested in clinical care. So I've diagrammed them here for your, just as a review pretty much. But here's the native hormone, PTH 1 to 84. Teriparatide or Forteo is the 1 to 34 portion of that molecule, and it has been used in hypoparathyroidism, and 1 to 84 was the formulation of Natpara that was used for a number of years in the treatment of hypoparathyroidism. You've learned a lot about transcon PTH, and here's the molecule, but PTH is just a little tiny, this little orange ribbon is just a little tiny portion of that transcon molecule, but it is 1 to 34 that is being given in the transcon preparation. The eniboparatide is a PTH-related protein analog, and it's being tested in hypoparathyroidism. I know this is a busy slide, but it's right here listed as AZP, and here's the sequence of it. These different letters are the amino acids that are in this peptide. And when it's yellow at this portion of the molecule, it's most similar to parathyroid hormone, our normal parathyroid hormone. And then this C-terminal part of the eniboparatide is more similar to the PTH-related protein. So in a sense, it's an analog of both of them kind of fused together. And the idea behind this was to have a peptide that would interact with the PTH receptor. Remember, you need that in order to have action of PTH, that would interact in a certain way, a certain conformation, if you will, of the PTH receptor. So that's eniboparatide. And you've also already heard about canvuparatide, which is also investigational, and it's the 1 to 30, this little ribbon here, this 1 to 34 PTH molecule that gets injected. It has fatty acids on it that allow it to bind to albumin, and then it gets slowly released to interact with the receptor over a longer period of time. So 1 to 34, but modified so that it can have this kind of half-life in our body. So these are some of the peptides that we deal with in the treatment and in the trials, in the treatment as well as in the trials for hypoparathyroidism. So what is going on in bone in people with hypoparathyroidism? Well, a lot of things happen, and some of them I've already showed you, but one of the main outcomes of chronic hypoparathyroidism is that bone turnover, that process of remodeling that I showed you in that cartoon, that is dampened way, way down. And we pick that up clinically by measuring those bone turnover markers that we talked about. We could pick it up in other ways, but that's one way where you can look at it dynamically. And the other way that we pick it up is that bone mineral density, the DEXA measurements, are going to be higher. The T and the Z scores are going to be higher. They're going to be positive compared to sort of control population, if you will. And I'll underscore that that is the opposite. The situation in hypoparathyroidism typically is the opposite of what we see in osteoporosis. In osteoporosis, those T scores or Z scores are going to be negative, and here we're talking about positive scores. And then this is just a table of people, of a cohort of people with hypoparathyroidism from Dr. Rubin's study, and you can see that what I've said about the bone density at the 4 different sites and about the T-scores is reflected in this cohort. All of these T-scores have a plus sign implied in front of them, okay? So that is what you see in a typical group of people recruited to a study of hypoparathyroidism at all the sites. And perhaps, you know, the spine tends to be having the highest T or Z score in hypoparathyroidism. So we're seeing low turnover as a rule, and we're seeing high bone mineral density as a rule. And you've seen this picture before. That's reflected in what's going on at the microstructural level, okay, with the control having open spaces in the trabecular architecture and hypoparathyroidism, that dense, packed-in microarchitecture. I know this is hard to see, but at the level of the bone biopsy, in the normal control, you're seeing layers of bone being laid down over time, and in someone with hypoparathyroidism, we don't see that same kind of bone formation. So all of this is borne out when you do, you know, sort of detailed studies of bone mass and bone metabolic activity. So what happens with PTH? I want to make one statement that I think is pretty important. It takes time to see the effects of almost anything on bone. So we're looking at a time frame, not like a blood calcium. You can get a level 1 day later, you can get a level 3 days later. Doesn't work that way with bone. It takes a while to really see what's going on, and therefore it takes a long time to assess the overall effects that a given treatment intervention is going to have. So the markers are dynamic, and we'll see that in a moment. They change, they can change over sort of weeks to months, but you do want to follow them over years so that you really see the full effect that they have, that happens. And the same with bone density, that's even slower. You're going to see changes probably in a couple of months to years, but again, you're going to want to follow that over years because that's a critically important parameter to have information on. So where do we have the long-term data? Well, we've got long-term data with PTH 1 to 84, and I'll show you some 6-year data, and I'll show you 12-year data from Dr. Rubin and her colleagues. And then we'll look at some data with TransCon PTH. We've got 52 weeks of data and that I think you've actually already seen. And then we'll look at the 4-year data from a trial called Path Forward. The eniboparatide and the canvuparatide, they're still early in phase 2 and phase 3 studies, so I don't really have data to show you on those. But remember that time is a really important parameter here. So what we're looking at here, so now we're going to turn to look at some of the 1 to 84 data. Okay, and what we're looking at here are bone turnover markers in almost 50 people with hypoparathyroidism who were on 1 to 84. The first part of the study was placebo-controlled for the first 6 months, and then 5.5 years of open label 1 to 84 given daily. Okay, and so we're looking at the bone formation marker, P1NP, and you can see that it starts out at the bottom of the normal range on average, goes up several fold, probably 5, 6, 7-fold over the first year or so, and then slowly comes down. Probably at about 2 to 3 years, it starts to stabilize and then remains stable for the rest of the trial period. This was, on average, higher than the upper limit of normal for this bone formation marker in this study. Over here on your right is the bone resorption marker serum C-telopeptide, and you can see that one also is at the bottom portion of the normal range and goes up just above the upper limit of normal, but does come down again over the same time course, establishing stability at about 2 to 3 years. So again, these long time frames are needed to kind of assess what's going on in bone and to know that it's stabilized. This is really a busy slide, not the best way to present the data, but we'll walk through it. So again, these are the bone density data by DEXA scan. And what you're looking at here, now these are the Z-scores. So they're comparing the patients in this trial to people their own age and their own sex. And these two upper curves are the lumbar spine bone density. Here, there are 4 curves here that are the hip bone density, and down here is the radius, just to kind of orient you. So the spine starts out with a Z-score kind of around +2, so 2 standard deviations above control, and it kind of moves around a little bit, but probably goes down only by about 2% over the course of 6 years of treatment. So pretty stable. That is a pretty small change in bone density. These sites at the hip, both the femoral neck and the total hip, a little bit of upward movement, but pretty much stability overall, about a 3% decline over 6 years. And then over here at the radius starts at about just under +1 Z-score and comes down to just under a Z-score of 0. And the radius loses the most with chronic PTH therapy, at least in this study, 7.5% to 8% over 6 years. Now, how do we put this into context? Well, of course, it's going to depend on your age, your sex, your menopausal status, all of that plays a role. But for example, in older women who are not immediately postmenopausal, maybe about 0.5%, maybe to as much as 1% might be lost each year. So this is giving you just kind of a benchmark, if you will, for thinking about how much is this and should I be thinking about it or concerned about it. These are longer-term data that come from Dr. Rubin's study looking at 27 people with hypoparathyroidism treated with 1 to 84 up to 12 years of therapy. This is a little bit, moves around quite a bit. But the P1NP, the bone formation marker, again goes up very quickly, peaks for the most part here early at 1 year, comes down, goes up again over here. So it still remains, if you draw a line through all of this, it still remains above the baseline that people started at. And the C-telopeptide, the resorption marker, also goes up again above baseline throughout the 12 years of treatment with PTH. Now, what happened to bone density during this time? So here we're looking at the bone density changes, and they express these as the percent change. And in the purple, you've got the lumbar spine, and you can see it goes up, reflecting the bone formation effects of PTH there. And it remains stable for a while and then comes down a little bit, but still remains positive at the spine. At the hip, these 2 curves are the hip measurements. They go up a little bit and they stay up, and then they start to come down here at about year 11 and year 12. But remember, of course, people in this study were 11 or 12 years older, and stuff starts to happen, as we all know, as we get older. But at any rate, these are the data. And then if we look at the radius over here, that's over here, the radius actually slowly declines over the course of the 12 years of the study. So these are the longest term data that we have in any kind of trial on PTH effects on bone. Now the path forward study, and just to refresh your memory, if you've seen these already in the course of the conference, the Path Forward study, we have data now up to just over 4 years of treatment in an open label format. So again, the first portion of the study was double-blind, placebo-controlled, and then went into open label right after that. And we're looking here at the mean CTX levels, and this is again the resorption marker, goes up. It's at the lower part of the normal range, goes up several-fold, 5, 6-fold at the beginning, comes down, and then remains stable here over the last, say, 2 years of this open label trial. And the bone formation marker, again, a very similar pattern, and then achieves stability. Again, quite a bit above what people started out at when they joined the trial. Now, what does that translate into in terms of bone density? And here we're going to look at the bone density Z-scores on your left and the bone density T-scores on your right. And what you're seeing over here are the different sites, the lumbar spine in green, the total hip and the femoral neck in purple and in blue, and then the radius, it's buried in here on the axis. But what you're seeing is that when you look at Z-scores, they're positive at the beginning, what you'd expect with chronic hypoparathyroidism. And with initiation and chronic treatment with PTH, they come down, and they come down a little bit and stabilize sort of over this 2 to 3 year period. Okay, the hip is a little bit less than the spine in terms of the initial score, and then it comes down as well over the course of therapy. And a similar pattern, we won't walk through it, but a similar pattern in terms of the T-score. So just a different way to kind of plot this bone density and look at the changes that occur. Now, how many of you know, many of you had raised your hand when I asked about how many had had a bone density done by DEXA. How many of you know your T-scores? 1, 2, 3. 3 of you. 3, maybe 4. Okay. All right. So what we have on this particular slide are the lumbar spine and the femoral neck, and the initial baseline T-score is over here. And this is obviously a group of people with hypoparathyroidism treated in the open label format for 4 years with TransCon PTH. And you can see that over here, this first line are people with T-scores starting out greater than 2. Okay, then the next category is greater than 1, between 1 and 2. Then you've got the normal bone density, and then you've got people with osteopenia. So depending on where your T-score starts, you can see they analyze the data with regard to the initial T-score of the individual that went into the trial. So you can see that if the T-score started out greater than 2, here you are at the beginning of the study, and then bone density comes down about a half to a little bit more in a T-score over the 4 years of the study. If you're in the category of greater than +1 to 2, that's this gray curve right here. Bone density comes down. Again, it's about a 0.5 to a little bit more in terms of the T-score change over time. And then if bone density is normal, you can see that it's right here, and it comes down a little bit over the course of the 4 years of the study. Now, what about those that were osteopenic? Here they are right here, kind of starting out in this yellow portion of the curve, and they come down to just a little bit higher than the range for osteoporosis. So everybody has a decline, and potentially, depending on where you start, you may have less if you actually start out with less bone. And a similar pattern over here at the femoral neck. So this is where we stand with regard to long-term TransCon PTH therapy. These are the longest-term data that we have, and this is the analysis that we have on that from that data set at this point in time. So just to summarize where we are, I think I've tried to emphasize that PTH plays a really important role in modulating bone turnover in our bodies. When we treat with PTH, we see very dramatic effects on those biochemical markers. There's intense stimulation of turnover. The markers change dramatically, and they stay changed for as many years pretty much as we measure them. We think that it's the years of sort of standard of care treatment that packs that bone. I want you to remember that picture of that dense bone that things start out with, because that's what goes on with hypoparathyroidism. And then PTH therapy does restore that turnover more to a normal level, takes calcium out of the bone, brings it into the circulation, and the bone density goes down because of that, because the bone density is basically measuring that mineral component. And I've tried to, show you a little bit about the different sites and how we use that information when we think about PTH treatment, when we think about osteoporosis, and so forth, the different sites that we measure when we measure bone density. But it's always really important, it's always critically important to sort of view what's going on in the context of the rest of your health as well. And as Patty always reminds me, it's the comorbidities that are also important to think about here. So how do we translate this into what might be going on in the individual's particular situation? Well, if you look at the guidelines for hypoparathyroidism, they're pretty murky when it comes to and I'm thrilled that everybody pretty much kept their hand up and said they'd had a DEXA done. But the guidelines are a bit murky. They say, consider a DEXA based on the risk factors and what's going on in the individual at that particular point in time in terms of determining whether you're going to do a DEXA scan. And if more people had not put their hands up, I would have said, if you haven't had one, it's a good topic to bring up with your endocrinologist. It's a good topic to consider if you're taking medications that can affect the bone as well as PTH or as well as having hypoparathyroidism. If you've got a history of smoking, if there's any substance use in your history, if you're exercising or not exercising, other diseases, your age, your sex, all of those things really have to get boiled into deciding when to do it, how often to repeat it, and so forth. The DEXA scan is what to ask for. Some endocrinologists are comfortable ordering and interpreting bone markers, but I think the DEXA is certainly something that everyone should be really comfortable with. And then sometimes the question comes up, if you're starting PTH therapy, should you get a baseline study? My own view is that it's not unreasonable at all, but in your own circumstance, it should be discussed with your prescriber, your endocrinologist. And then the other question that often comes up is, should that DEXA be repeated? And if so, when should it be repeated? And I think we don't know. I've tried to share with you the data that are out there that I could find about long-term effects of PTH, but I think you have to review your own individual situation with your endocrinologist and decide when the time is right to repeat those studies and how often those are going to be followed. I don't think we have, firm evidence-based recommendations to be able to say this is the way it should be. But I think we do now finally have some longer-term data, and remember that long time frame for looking at effects on bone. So with that, I'm going to thank you for having me. Thank you for paying attention, staying, and be happy to take questions or discuss whatever you'd like.
All right, let's give it up for Dr. Shoback. All right, we got lots of hands going up in the room, so let's start back there with Bob. Okay.
I have a bunch.
And please stand as you
Hi,
talk.
I'm Liz. So even the people that were on PTH, their numbers went down. Why bother to get the scans, or why get your brain scanned? If they can't fix it, why do I want to know about that? That's one question. And then at one point I was taking collagen because it helps with skin, so you slow down aging. And I was on NetPar at the time, and I had to lower my NetPar dose, and I felt worse, so I gave it up. But that's because it works with bones. I didn't know that, if you can comment on that. I guess I'm wondering too, if PTH takes calcium out of my bones, why do I have to eat calcium or take calcium pills too? And then people that need a higher dose of PTH to hold steady, do they have higher bone turnover, or they just have worse absorption? Or is it based on their age, their weight, stuff like that? And then with enable paratide, when you had the slide where it had the letters, it kind of looked like a word search. How come you couldn't get all the letters to match up?
How about let's give her a chance to
Maybe
answer
we-
a couple of them, because that's a lot.
Thank you.
Okay.
It's hard to know where to start. You have so many really great questions. I guess I would say the last part is a very interesting question, which is, do those markers change as a result of adjusting the therapy? And that is really a fascinating question. I'm sure some people have data on that. I don't have it at my fingertips, but it wouldn't surprise me one bit that if you need to go to a higher dose, and maybe somebody in the audience has an answer, maybe Michael, he has so much information at his fingertips, but maybe, if you need to go to a higher dose, for example, of PTH or TransCon or something to get the blood calcium, it's possible that the markers will go up. I don't think that we've actually captured that information, but it must exist in somebody's data set. So it's a really good question. And then collagen, I'm not really sure what to do with collagen in terms of, hypoparathyroidism. I'm not sure I don't think we just have any information about it. What
Okay.
were any other?
How about if we're going to take those questions and we'll get back to you.
Oh, that's a
We'll
good
do
idea.
that so that we've got a lot of questions in here, but keep those for us, Liz.
Okay. One other one. Why did people let you sample their bones? I would think that would hurt.
Oh, why should we measure?
Why? Yeah.
Why do we need to know?
Why would they? Because she said, isn't that painful? Why would people let them do it?
Oh, the bone biopsy. Oh, forgive me. I thought you were talking about why would we want to know our DEXA measurement if we can't do anything about it or something. The bone biopsy, I think people were certainly willing to, provide this information. Before Dr. Rubin and Dr. Bilezikian did these studies, there was a study in 1996, one study with, I think, 6 biopsies in it, of what was going on in bone in this condition. And that's not much information given, how significantly important bone tissue is in hypoparathyroidism. So I think that the people that volunteered for it wanted to find out as well, and they did contribute some really valuable information by doing that.
All right. Katie?
Okay. Just to comment on that bone biopsy, having worked in pathology, it's kind of a painful thing, I think, to get a bone biopsy, and also they bleed a lot. So it's not something you do just, because you want one. Anyway. But my question is, I've been hypoparathyroid for about 22 years. My DEXA scan has always shown osteopenia, and I still keep going down to the point now where I'm considering therapy for TEO. Why do you think my bone density is not high after all these years?
Yeah, wonderful question. And I think that what I've presented to you is what's in the literature. And I think that as we get, registries going where we really look very carefully at the sort of diverse population of people with hypoparathyroidism, we'll have a better representation of women, for example, who are postmenopausal, who don't start with those high bone densities. I think that we've been driven by, the field has been driven a lot by, what people get studied. And there's a range of bone densities, and everything we looked at in all those data slides are averages. And some of those slides, you can see a pretty wide range around that average. And there are plenty of people that start these studies, and I think that's what those last few slides show us with the TransCon data. The green, the yellow, and the red, the coding, are people that start at different places when they begin PTH. So I think that maybe on average, or the people that volunteer to be in studies are the ones that have had the disease longer, et cetera, and we get those plus T-scores and those plus Z-scores, but there's a range. And people are going to look at bigger groups of patients with this condition and study it a lot more. And I think Dr. Khan has a really nice paper that just came out on her registry in Canada that looks at, and a fair percentage of the people with hypopara in her registry have osteopenia. They don't have the positive scores. Yeah.
All right, we're going to take a few from Michelle online, and then we're going to go to Heather.
Okay. At what age should patients start getting a DEXA? This came in from a parent of a pediatric child, wants to know what age should they is there a recommendation, and then how often?
So with regard to children, there isn't really even a firm recommendation in the guidelines for adults. So I think making a firm recommendation for children is difficult, very difficult, because we just don't have a lot of information. And even interpreting DEXA scans in children is pretty challenging, because the age and the pubertal maturity and all of those things, and the height, and I mean, there's so many factors that go into it. I'd be very nervous to say anything about children. With regard to somebody beyond, say, the age of 21, looking at these data, I kind of think that if you're going to initiate PTH therapy, I think you'd like to have a baseline. But I think it's important to talk it over with your endocrinologist and make sure that we're all on the same page. But once you're got a a mature skeleton, I think it's not unreasonable to get a baseline if you're certainly going to start PTH therapy.
And someone asked, is there a way to measure our bone quality rather than just our density?
Yeah, and I left that out, but they're absolutely right. So there are the high-resolution peripheral QCT, which is only used pretty much for research, is a way to look at bone quality. It's got a lot of other parameters than just the simple DEXA measurements in it. And then the TBS, the trabecular bone score, which you might see on some of the DEXA reports that get done. And that's a way to look at bone quality using the DEXA images of the spine. So that's a way to get at quality. Other than that, those are non-invasive ways.
Are there any studies that are currently doing that?
Yes.
Okay.
In fact, it's being done in the path forward and pathway, and also in the anepoparatide studies.
That's good.
And they're also doing the HRP-QCT.
Okay,
To get it.
one more, Michelle.
Okay. Does low bone turnover in pediatric patients affect their growth?
Well, bone turnover, when kids are growing, bone is turning over dramatically. The net, it's a good way to think about it is like a bank account. When you're a child, you're building up that bank account, okay? So that the turnover is happening, but there's a net gain until you reach your peak bone mass, whatever age that is, 18, 20, 25 maybe, whatever it is, you reach that peak bone mass. And then that remodeling process, while you're at peak bone mass, hopefully keeps you stable at that level until, for a woman, perimenopause sets in and bone density starts to go down. Or for men, really, bone density is preserved unless illnesses set in until you start to have age-related bone loss. So I'm not sure that answered the question. Hopefully that's close enough.
All right, Nikki, and then we're going to come up to Heather.
Dolores, that was really great. I was just actually related to the question over here. I also noticed with the patients with osteopenia, they continuously lose bone. And I just wondered whether really we should be considering treating with PTH differently, in more in an anabolic fashion that you do with Forteo, rather than the continuous treatment with constant PTH levels.
Well, I mean, I think we're treating two different things. Are you talking about the treatment of people with osteopenia and hypoparathyroidism?
Yes,
or,
in the data you showed here.
It may evolve to, I think these are very, very new data. These are data that have been presented at the last bone meeting and are fairly new with this formulation of PTH, and I think it will require, rigorous peer review. It needs to all be, put through the peer review process, and we need even longer term data to really, prove that stabilization occurs. Whether we should change the way that we're treating hypoparathyroidism, I don't know, because the goal in hypoparathyroidism is to maintain, the serum minerals and calcium and urinary calcium in a desired level, because that's a whole different, goal than the treatment of osteopenia or osteoporosis. But it definitely needs to be, thought about very, very carefully.
All right, Heather?
My question is, ouch, when you go to get your DEXA scan, they always tell you do not take any of your calcium, but they're not really clear why. And then when you tell them, well, I've got hypopara, I've got to take my calcium, and they look really perplexed, and they're like, well, we really don't want you to take it, but if you're going to take it, go ahead. So is there a reason why? Because they never have really given me a clear reason why you're not supposed to.
Well, I've asked the same question myself because my patients ask me the same thing, and I don't want a tetany or tetany attack on the DEXA table or a seizure or anything.
Yeah.
So I've asked, and they say that sometimes they pick up the calcium tablets as they're going through the GI tract, and I said, well, isn't that going to be different than the spine and the hip and so forth? And usually they say yes, and it's okay. So that's the answer I've gotten, but I believe it's the artifact from taking calcium and having a high amount of calcium in concentrated parts of the GI system. Because, if you think about the hip and the spine, it could interfere, I guess. So I've let people take it. I feel like it's more of a risk than not. And if there's a problem with the DEXA, we can make an adjustment, but I've never had a problem.
Okay, thank you.
Dr. Kohlmeyer?
Yes, Lynn Kohlmeyer, thank you so much. That was fantastic. So we talked about this earlier, and I was just so grateful with that new data that bone density didn't continue to drop, that it kind of stabilizes. And so I really want everyone to have heard that. And what do you think, because I know we've contemplated this, if you're on parathyroid hormone replacement, you have hypoparathyroidism, either you started out with osteoporosis or now you're in a lower range and you want to prevent that, can we treat you like we would otherwise do, but without a PTH analog? Because that hasn't been studied yet. Good question. And just be careful of hypocalcemia. What about Evenity? What about Reclast? What about Prolia? And, I don't want my patients fracturing if they're not the ones that started high and are still high.
Yeah, no, I think, those of us who do research in this field have to pay close attention to everything you've brought up, Lynn, and thank you for bringing it up. I mean, I do think that, this is all new information and important information because this is the formulation of PTH that we are currently using, and we want to do the best job by everybody's bones as well as by their blood calcium. So we're going to have to study it. Without research in that kind of with studies like that, we aren't going to have that information. We can give an opinion, but I'd rather have some data to base that opinion on, frankly. So I don't know the answer.
We have one more question in the room and one more question there.
Hi, Dr. Shoback. We need no introduction. We know each other. I had a couple of questions. Obviously, I could see the overall trend of everything you were talking about. Without having the graphs next to each other, I was wondering what the treatment with 184 versus the 134 was versus as in net para patients versus transcon patients, what if the bone density has had any differences in them?
Yeah, it's a really good question, Rachel. I mean, the thing is that the populations are a little bit different. It's really hard to say. The compounds are different. The half-life is different. There's so much that's different. It's really hard to say. I showed you what we have. I mean, I think the pattern, the radius goes down, probably the radius is the lowest to start out with and goes down perhaps maybe quantitatively the most. The spine tends to be preserved on average, but all of these things have to be looked at, I think, in the context of the individual. Is it a postmenopausal woman? Is it a man? Is it a premenopausal woman? That sort of thing. And we don't have the data on 1 to 84 that I know of, divided up that way to make the kind of comparisons that, we'd like to have. Somebody may have that data, but we don't have access to it, and it isn't published. Okay. So, it's very difficult to compare the two.
That's fine, thank you. I was just wondering. And then this is just a very quick question. I wasn't familiar with eneboparatide, and I was just wondering, that's something that's in study now? Which study is that?
Yes, that's a study called Calypso. And it's that PTH-related protein analog, and it's a daily injection of that analog for hypopara. Yeah.
Okay, Michelle, last one.
Yes, before I ask the last question, because I have a ton that are coming in, would you, just so the online audience can hear this, would you be open to us maybe giving you some of these questions and you giving us some responses that we could just share out on our webpage at a later date?
Sure, of course.
Okay, and then I'm going to, I'm trying to decide which one would be most beneficial here. What is the impact on bone healing for hypopara patients when they do fracture? Is there any difference? Do we heal differently?
Wow, what a great question. I'm going to see, Lynn or Michael, do you have any experience with that? Michael's shaking his head. I don't think we have experience with it.
Okay.
And thank goodness I don't have too many people who have fractured where I've seen any problems, you know, so I don't know.
Okay, all right. Thank you very much, Dr. Shoback.